The first annual Riordan IVC and Cancer Symposium proudly presents New Frontiers of IVC Research. Your presenter, Xiaolong Meng, MD.
Our first speaker is Dr. Xiaolong Meng, and Dr. Meng has been an instrumental part of our research staff. He is the on-site head of research here. And Dr. Meng is a medical doctor, but he's devoted his complete attention to investigating the role that nutrition, hormones, cytokines, oncogenes, just all the various components that go into what sustains cancer. Why does cancer occur? What sustains us? What can we do to end it? And so we are very pleased to have Dr. Xiaolong Meng offer what I believe will be a kind of bringing together of many of the diverse comments that we made yesterday. I kind of sense a consensus occurring, and let's see if what Dr. Meng has to say, if that doesn't kind of bring additional weight to what we were talking about. So with that, I'd like to introduce Dr. Xiaolong Meng.
Okay, I'll just put this on here.
Thank you, Dr. Rong. Good morning.
Good morning.
My presentation today, the topic is a new frontier of IVC cancer research. There's many sayings in our lab. One of them is that any investigator who make a pointed effort to find a cancer cure is likely to develop, after a decade or two of failure, a feeling of futility and frustration. I have been working in this cancer field for more than 20 years. You can feel my feelings. And another one is that believing nothing just because a so-called wise man said it. It is written down in books. Belief is generally held. Someone else believes it. Believe only what you yourself believe to be true. That's one of the drives that keep me still working in this field. Here is the outline of my presentation today. The new theory of cancer. Cancer is a functional tissue for wound healing. The evidence is to support the new theory. The role of the IVC in the new theory. The last one is the implications of this new cancer theory on IVC protocol. Excuse me. Now let's talk about the new theory of the cancer first. The current cancer theory holds that cancer is a genetic disease caused by the progressive accumulation of mutations in critical genes that control cell growth and differentiation. Most mutations can be repaired by our system, but some of them escape and form a cancer. With the accumulating mutation theory, it is hard to explain the following phenomena. More than 50% of the SD rats will develop spontaneous tumors in 2 years, while it is less than 0.05% in humans at 2 years old. The doubling time of the SD rat's bone marrow stem cell is 1.49 days, and the human mesenchymal stem cell is 1.64 days. The division rate of the SD rat is similar to humans, indicating the chances for the SD rat's mutations should be similar to humans. Why does the rat have more tumors than a human at 2 years old? Sprague-Dawley rats. Yeah. Bacteria are in the human colon, all the time. If the mutation causes colon cancer, why not on the bacteria in the same environment? The cancer incidence rates increases along with the age until 85 years old. After that, it declines. If the mutation caused the cancer, why does the cancer incidence lower after 85 years old? If the cancer is not a mistake by a mutation to genes, we may need to look at it from another angle. Let's look at some facts first. Cancer only occurs in organisms with wound healing capacities. For example, a pine tree, it can live up to thousands of years. There's no wound healing, there's no cancer. You just think about the pine tree, exposure to a sunshine, a UV, for so long, every day. But there's no mutation. Or we say in this way, there's no single or the mutations or copy mistakes cause a tumor in the tree, although the cells divided every day. Another example, protozoa. They can live million years, but there's no wound healing, no cancer happen on them. For short life insects, for example, the Drosophila, they can only live up to 30 days, but they have a wound healing and they have cancer. Another example, the long life insects, queen termite, they can live up to 50 years. No cancer, no wound healing. For the mammal, they have the wound healing and they have cancer. The wounds are involved in pre-cancer diseases. For example, the smoking causes the chronic inflammation of the lungs and is a risk factor for lung cancer. Inflammation of the liver, colon, and the prostate increases the risk of the cancer developing in those tissues. Cervical erosion is a risk factor for cervical cancer. Ulcers are the risk factors for the gastric cancer. Oncogenes are involved in growth and wound healing. The oncogene is originally defined as a gene that contributes to the production of a cancer. However, oncogenes are expressed not only in cancer, but also in pregnancy, embryonic development, wound healing, and a growth factor synthesis. Oncogenes also have broad anti-apoptotic functions. All those commonalities between the wound healing and the cancer above point to a mechanism evolved by the nature and lead us to a new cancer theory. Cancer is a functional tissue for wound healing. When a wound occurs, the body starts the wound healing mechanisms. Many repair cells are used for the replacing the dead cells. However, if the wound is persistent, local repair cells may be exhausted. Then the oncogenes will be activated to secrete more growth factors and the cytokines. The factors will recruit more repair cells to the wound site, cause the differentiation and repair the wound tissue. Mostly, the wound is healed. Oncogenes are deactivated, and the metabolism goes back to normal. However, if the wound is still persistent, like a chronic inflammation, chronic infections, more cancer cells are divided rapidly to secrete more growth and repair factors for wound healing. Then a clinical cancer forms. After the wound is healed, the cancer cells can be redifferentiated or apoptotic. Then the clinical cancer mass will be gone. But if a small cancer cannot heal the wound, the tumor mass will continue to grow until the wound is healed or the whole system is exhausted. Now we can explain those phenomena that are hard to explain by mutation theory. Why the rats had more tumors than the human at 2 years old. The rat lifespan is 2 to 3 years, while a human lifespan is more than 100 years. Many apoptotic and malfunctioning cells exist in the old age body of the rats at 2 years, turning the oncogenes on frequently to heal the wound, while those old dead cells are not in the 2-year-old human, so that the cancer wound healing mechanism needn't be activated for that reason. Why does the colon develop cancer but not the bacteria in the same environment? Because a cancer program exists in human cells for wound healing, while the bacteria have no wound healing mechanisms and no such program, no cancer. Why does the cancer incidence lower after 85 years old? The functions of all cells will decrease when they are getting old. Cancerization is a function of human cells, and it decreases along with other functions after the cell is getting old. Age 85 probably is the turning point that cells were really getting old in average. The old cells have less power to respond to a wound. Is there any evidence to support the new theory? From the literature search, we found that tumor cells secrete functional repair molecules, many of which are also produced during wound healing, indicating tumor cells may help wound healing. The expansion potential of stem cells is lower in cancer patients than in normal control, indicating the stem cells are consumed in the cancer. Stem cells shorten their telomere during divisions, and they can become cancer cells in the wound, while the telomere in cancer cells is much shorter than that in non-cancer cells, indicating that cancer cells might be from the exhausted normal repair cells. The fact that pathological cancers are found during the autopsy as a higher incidence than the clinical cancer suggests that subclinical cancer may be working on the underlying wounds. If the tumor suppressor gene p53 is activated all the time, the mice do not get cancer. However, they display an early onset of aging in their lives, including reduced longevity, osteoporosis, generalized organ atrophy, and less stress tolerance. This phenomenon indicates that cancerization is a necessary mechanism in the mammal's lifespan. The fact that to prove the cancer cells' growth can be regulated in the non-toxic environment, we incubated 3 tumor cell lines in the culture with the different proportions of the median components. The 3 tumor cell lines we used were breast cancer cells, prostate cancer cells, colon cancer cells. The culture median was regular culture median with 1 to 100% of fetus bovine serum, FBS. The results show that all the 3 kinds of tumor cell lines grow best at 10 to 20% of FBS, which is the standard culture median, but were inhibited at lower or higher proportions of the basal median and the FBS. There were no toxic elements in the median, but the molecular balances turned the tumor cells proliferation on or off. The same situation may be happen for tumor masses inside the body. That might be the reason why spontaneous regression happen in cancer patients. This test indicates that tumor cells growth is conditional. Their proliferation are activated when the environment is close to a wound situation, and deactivated when the environment is closer to normal. The standard culture median is not the situation closer to normal. That's why the tumor cells are immortal in the standard culture median. If the culture conditions are changed without any toxins, tumor cells will no longer be immortal. To prove the hypothesis that cancer is a functional tissue, we have developed a new C6 glioma model on Westerhan rats. First, we tested by injecting C6 glioma cells intraperitoneally, IP, into the different rats, SD rats and the Westerhan rats. And only Westerhan rats developed a small tumors. From the concept that tumor growth is conditional, we speculated that C6 cells may see Westerhan IP environment as a marginal wound area. Therefore, some further wound situation may provoke cancer cells to respond. From the literature search, we found that VC levels were reported to be higher under stress, higher in wound, and lower in delayed wound healing in mice and rats, indicating that higher VC is generated and responded to the wound healing process in rodents. Therefore, we may generate a similar wound healing process by injecting a large dose of vitamin C in rats. Therefore, we injected vitamin C IP at 700 milligram per kilogram into Westerhan rats for 2 weeks, and collected the serum before and after the injections for protein array test, PAT. The PAT is a single test for 58 cytokines and the oncoproteins. Cytokine is the protein secreted by cells and regulates many cell functions, including cancerization and wound healing. Oncoprotein is the protein expressed by oncogenes to execute many functions, including the cancerization and wound healing. The PAT results show that 28 out of 58 markers were significantly changed after VC injected for 2 weeks. Those markers are related to cell proliferation, apoptosis, stem cells, and wound healing. This indicates that VC at this dose may induce mechanisms that are close to rats' own VC wound responses. In other words, VCIP might generate a wound process situation in the rats. Then this VC-generated wound process was introduced into the C6 inoculated rat model, and the big tumor formed. The big tumor was not stimulated by VC directly, since 93% of the C6 cell growth was inhibited at the same dose in vitro. After the tumor formed, the previous significantly different markers under the wound process were mostly corrected. The upper figure shows that 28 markers that was significantly different before and after the wound. The lower figure shows only 4 markers above still remain significant, and the 86% of them were corrected by the C6 tumor, indicating the tumor works to correct the wound situation. When the PAT was analyzed comparing with the normal ranges, many abnormal markers were seen in the wound group, while much less abnormal were seen in the C6 tumor group, indicating that tumors worked to correct abnormal markers from the wound process situation. The normal range of each marker was from 24 rats without any injection. The abnormal values were defined as beyond mean plus minus 2 standard deviation of normal ranges. Interestingly, one C6 tumor rat did not develop a tumor, but it showed more than twice the abnormal markers than the others. The lack of a tumor might be due to the C6 cells injection into the muscle instead of the intraperitoneal cavity. It implied that oncogene's activation condition is very strict, and that the wound condition might be different in different tissues. This might be the reason why the blood metastases tend to select specific tissue more wounded, and it's very rare on skeletal muscle. In the tumor group, the developed tumor weight negatively correlated to their serum PAT abnormals, indicating the tumor is functional in correcting the abnormals. The C6 tumor expressed many cytokines and oncoproteins. The immunohistochemistry IHC on the tumor tissue showed that 22 out of 54 markers were positive. The left two images are the examples of IHC. The bluish color indicates the stained proteins. The upper one is the neuron-specific enolase, a protein expressed in brain or tumor tissue with functions-related differentiation. The lower one is the CJON, an oncoprotein with functions of cell proliferation, differentiation, and apoptosis. For those 22 positive markers in tumor, 15 of them showed a correction on abnormal PAT markers under wound situation. In other words, C6 tumors secrete those proteins and finally brought the corresponding serum abnormals back to normal. Therefore, the C6 tumor showed some negative feedback effect to correct the abnormalities on this C6 tumor model. The results of our in vitro and in vivo test indicates that cancer cells can stop their proliferation anytime under non-toxic conditions as long as the molecular balances are appropriate. Cancer is a functional tissue for wound healing. It may provide some negative feedback mechanisms to correct the wound abnormals. What's the role of the IVC in the new theory? Let's look at the IVC interactions in the cancer patients. Since diet, supplements, lifestyle, and the disease status or stage all affect the metabolisms of the cytokines and the oncoproteins, the study of the marker changes is much more difficult than that on rat studies. which all are under the same conditions. But we found that for just one-time IVC on 6 cancer patients, 4 out of 6 patients showed some abnormal marker corrections, but the overall pre and post IVC did not show the significant change, indicating the IVC response was individual dependent and other factors might be involved. To see more molecule metabolisms, Ray-Biotech cytokine kit of 174 cytokines were tested on the 12 IVC cancer patients and the 8 normal people with age of 20 to 40 years old as a normal range. In this case, 1 IVC infusion decreased 77 abnormal markers. In this case, 55% of abnormal markers were decreased after 6 IVC infusions. For all 12 patients, 58% patients had their abnormal molecules decreased consistently, meaning that decreased after both 1 and the 6 IVCs. But 25% patients had their abnormal molecules increased, and 17% had mixed results, increased at the first IVC but improved after 6 IVCs. However, the overall pre-IVC and the post-IVC of 12 patients had no significant difference, indicating again that the other factors might be involved in the IVC anti-cancer treatments individually. From the above in vitro, in vivo test and the clinical IVC uses, it can be speculated that the VC works through the molecular balances to signal cancer cells to inactivate it. The reason for the cases with good response after IVC on cancer patients might be due to the molecular balances by IVC plus other possible nutrients adjustments so that the underlying wounds were towards the healing and more cancer cells quit to work. However, the same IVC infusion may not get the same response to the different cancer patients. To heal the wound completely, other molecular balances need to be involved. In addition to plasma VC level, we need to monitor more molecules, such as cytokines and oncoproteins. What's the implication of this new cancer theory on IVC protocol? Since cancer is a functional tissue for the wound healing, and anti-cancer treatment should help cancer on wound healing rather than killing cancer cells. Killing cancer cells is working against the body's attempts to heal. It can only be used for buying time for completion of the wound healing process. Destroy cancer cells without heal the underlying wounds will allow for eventual recurrence. Therefore, the new cancer theory implies that IVC should be aiming at generating a wound-free environment so that cancer is no need to work anymore. We can use a math model to illustrate the VC anti-cancer mechanisms. Z-axis is disease, tumor size, or cancerization. X-axis is the dose of the vitamin C or some of the other molecules. Y-axis is the other molecular balances. When VC is optimal and the other molecular balance is max, Z will be minimum. that means you get cancer-free or you cure the cancer. When VC, vitamin C, is optimal, but the other balance is minimum, Z will be half. You get only partial clinical response. When VC is not optimal, other molecular balances can't make the cancer free, although the max Y can make the less cancerization. The complexity of the VC against cancer is not only that VC needs the optimal dosage, but also needs the other molecular balances. The math model here is not only 3 dimensions, but rather hundreds and thousands of dimensions. Most of the time, Y is a function of X. How to give IVC? According to the above math model, only at the optimal dosage will IVC be effective, not the higher the better. IVC is not aiming to kill cancer cells. IVC is aiming to generate a wound-free environment where cancer has no need to grow. Other nutrients or molecules must be balanced to reach the IVC anti-cancer effect. In other words, IVC alone cannot predict the anti-cancer effect. IVC dosage should be adjusted individually for the optimal molecular balances, for example, monitored by the levels of other nutrients, cytokines, and oncoproteins to make sure the IVC plus other integrated treatments drive those metabolisms towards normal direction. I would like to introduce our small research group on this work. From the left, Andrea Rogers does excellent work on the protein array test, and especially on the red tail blood collection. Dr. Zheng Lianying does the excellent work on pathology. Dr. Jie Zhong does the excellent work on the cell culture. Thank you.
We actually have time for questions. Okay,
Hi there. I found your presentation fascinating and kind of affirming some observations in clinical practice. I was just curious, when you were talking about the IV vitamin C infusions, what were doses that you were using in your patients?
Okay, for that experiment, we gave the IVC as the protocol in our center. The first one is the 15, the second one is 25, and the third one is 50, and I keep that 50 for 6 times. So we draw the blood before and after the IVC, and trying to find out whether there's any cytokine and oncoprotein changes after the IVC. What I mean is how IVC affect those molecular balances.
Well, I understand the remark that you made to me at lunch the other day, yesterday, when you said that this may help to explain why people are getting better results with lower doses of the IV vitamin C. So basically you're saying that it's not, the job here of the vitamin C intravenously is not to kill cancer cells, but to try to get an optimal concentration or orthomolecular concentration in order to get the wound to heal so that the cancer is not necessary anymore. Is that the basic thing?
Right.
Now, in terms of a practical situation at this point, are there any kind of commercially available markers that we can use to determine whether we're on the right track or not?
Yeah, there's many commercial markers you can use, but for the interpretation, it's very difficult. That's why clinically right now probably nobody used that for this the treatment guidance. For example, the cytokines and tumor markers or the oncoproteins we tested is very sensitive to other situations. For example, your diet, your lifestyle, the stress, and many other things will affect the results. So it's very hard to, for example, that's probably the reason we cannot find the statistical difference for those groups before and after the IVC treatment, because the human, when you give the human the IVC, they are not following the same lifestyle, the same diet, or the same situation. What I mean is the condition is totally different. So the IVC is only one factors affect the oncoproteins on those molecules.
One other question. Is there anything else in the literature that suggests this? This is a totally new theory, because I've never heard anything like this before.
Yeah, I think that's new. But we published the... Thank you. We published the hypothesis in 2005, at the end of 2005. And just recently, we found some new evidence to support this hypothesis.
Magnet, congratulations. Wonderful.
Thank you.
I am just so excited about this presentation, and I've been telling Dr. Ron that I've been working in Tokyo with Dr. Kobayashi, an MD, PhD, molecular biologist, oncologist, pathologist, and he got funding from a church, the Sun Moon Church, to follow patients for 10 years using very sensitive early cancer detection markers, a whole panel, which I ask everybody to go to Gordon Research and read his paper, because it was published in Cancer, and he actually tested Ronnie Reagan. But what he showed is that we all know there's a 7-year time lag before the cancer becomes the lump bump stage. But this is giving me such big hope, because in his work, what we did is simplified the diet. Whenever the patient had abnormal tumor markers, we did everything that everybody in this room would do. Simplified the diet, more sleep, started to detoxify, took immune support, all the stuff that we believe in. But in every case, always the tumor marker test went back toward normal. But by you using this example, you've opened up, because we had the tougher cases, we would do some hyperthermia. Well, we know hyperthermia is lowering the total level of toxins, going back to all these multiple possibilities. We want to put the good things in and take the bad things out.
Right.
And when I look at a simple trick, I was able to cancel most pulling of teeth of a hot tooth on a child by doing a big thing. You buy a simple magnet for 50 or 75 bucks a neodymium, and you buy a laser pointer from Office Max. You put the laser pointer over the sore tooth, and you take the magnet, go north and south. Now you have a pulsed magnetic field with laser. Laser is giving electrons, which are photons, which is giving energy. You stop the hot tooth. So I love what you've opened up with the idea of wound healing, hyperthermia, pulse magnetic, laser, and all the things that we believe in will have a much bigger possibility. I thank you so much for this exciting presentation.
Thank you.
I came to medical school with a liberal arts background, so I come with a different view. And harking back to first year of medical school, they taught us about how cells were made and how there's a quality control system, and how that quality control system checks out all the cells and fixes the ones that it can, and that it destroys the ones that it cannot fix. And so when it came to cancer, I was surprised when my doctors, my teachers were surprised that a breast cancer patient could years later have a colon cancer problem or have a totally different cancer. But it seems to me to be a quality control system problem, which certainly vitamin C and nutrients and diets are rebalancing. I'm just a lowly liberal arts person. What do you think about that theory of the quality control system?
Yeah, the multiple cancerization probably is because of the nutrients difference in different tissue. For example, you have the breast cancer, and after that removed, or even not removed. It doesn't mean the other places you don't have any wound there. For example, the colon. You may have the colon at the same time. So that's why one tumor generated, and the other one probably is still in the subclinical process. And many times, actually, one tumor probably will generate enough molecules to correct the abnormals inside the body. But this is not happen all the time. So that's why you removed one cancer from your body, and then the other subclinical one is still going on, and kick out the other one. So that's what I understand.
I have one question. It's very interesting, but I'm wondering, in your mathematical model, why you subtract from vitamin C other molecules which cause balance? Why you did not add to this why it's minus? From vitamin C you subtracted other molecules that can cause balance, and from where did you take this formula? And is it some calculation, so it's simply came in your mind?
This is the pen?
Plus.
Push that.
Okay, actually, this is, I just trying to emphasize the vitamin C and the other molecular balance. It's not separate from the others. The vitamin C on this model is not the unique one. You can replace the vitamin C as the other molecules, for example, vitamin B or vitamin D, same thing. So the x-axis is just the treatment, your treatment molecule. And then the y-axis, the other molecules, molecular balance. What I mean is the treatment molecule, you need to reach this optimal dose here. That's the optimal dose. And at the same time, the other molecular balance need to be max, so that you can reach the cancer-free point here. So on the other situation, if here, for example, here, the VC is not optimal, and the other molecular balance is not optimal. So you don't get the cancer-free situation. You probably get a partial clinical response, but not the complete one.
Okay, thank you very much.
The first annual Riordan IVC and Cancer Symposium was brought to you by the Center for the Improvement of Human Functioning International, located at 3100 North Hillside, Wichita, Kansas, USA. To learn more about the center and what we have to offer, please visit us on the web at www.brightspot.org.